Hi, and welcome to today's presentation on the stages of labor. And so today we shall look at the first stage of labor, second, as well as the third stage of labor, and say something small about the fourth stage of labor. So we shall begin with history taking. History and physical examination is very important when the woman presents. And so what we have to do is focused history, and this focused history must give us information or must elicit information such as the frequency and time of the onset of contractions. The frequency and time of onset is very important because sometimes we may have false contractions or false labor, and so we need to know the frequency of the contractions as well as when it started. Also, we need to, ask whether the membranes have ruptured. If yes, when did it rupture? Then we need to find out the, state of the amniotic fluid. Is it clear or is it stained with meconium? These are all very important. If it is stained with meconium, then we have to, provide the appropriate interventions to prevent infections and asphyxia in this baby. As well as we also need to, find out whether the woman still, feels fetal movements. Then we need to, ascertain whether there is presence or absence of vaginal bleeding. If there is presence of vaginal bleeding, we need to look for the cause of the bleeding and, intervene by finding, the way to stop the bleeding. Now, as I said, the contractions may be false, and so we have two main different forms of contractions which the woman may present with. The first one can be what we call the Braxton-Hicks contractions, and this usually, is characteristic of false labor. Then we may have the true labor contractions. So how do we differentiate between a false labor contraction or Braxton-Hicks contraction and a true labor contractions? Now, the Braxton-Hicks contractions usually occurs once or twice per hour, and usually it occurs few times within a day. Whereas the true labor contractions starts as infrequent about every 10 to 15 minutes. Then as time goes on, it becomes frequent about every 2 to 3 minutes. Now, the next thing that we can also see is that the Braxton-Hicks contractions are usually irregular, and also they do not increase in frequency with the increasing intensity of the contractions. So that is Braxton-Hicks contractions. When we compare it to the true labor, what we find is that the contractions in true labor last longer and in intensity. As we said, it must last for about 30 to 45 seconds. Then the last thing that we also see is that in Braxton-Hicks contractions, the contractions usually resolve. They tend to resolve when the woman starts walking or when the woman, changes the activity that, she is doing. However, it does not lead to any cervical dilatation or effacement. You understand? So that is it. When we compare it to the true labor, what we find is that it is accompanied, the contractions are accompanied or they lead to cervical dilatation. And so we must try and differentiate between a false labor contraction and, true labor contractions. After knowing this, then we have to go ahead and manage this woman in labor. And so, as part of our management, what we have to do is that when the cervix is 3 centimeters dilated, we must admit this woman. As we admit this woman, we need to start, measuring the vital signs, which I'll talk about later, but we must make sure that the bladder is empty. Why must the bladder be empty? This is because if the bladder is full, it may obstruct labor or it may even impede the descent of the fetal head. And so we must make sure that the bladder is emptied. Then we also need to, set or get an IV access, because we are going to give, medications to, this woman, as well as some IV fluids to the woman. And so we need to get an IV access. Then we need to monitor the vital signs. Very important. The vital signs that we take when the woman comes is going to serve as a baseline record so that throughout labor, if there is any deviation in the vital signs, we can compare. So that, for example, if the woman's blood pressure increases so high, we compare it to the baseline to see whether there is any abnormality or not. Another important thing is the fetal heart rate. We need to also, auscultate or measure the fetal heart rate, especially during contractions. This is because when the uterus is contracting and we find that the fetal heart rate is decelerating, then it means there is a problem. If the fetal heart rate also increases so high, then it means there's a problem. And so it is very, very important that we assess the fetal heart rate to know the state and condition of the fetus. Then we must also make sure that we do not restrict the woman from eating. However, we must encourage the woman to take light diet and also clear food or clear fluids. The reason why we must encourage clear fluids and light diet is because in the circumstance, if the woman needs to be taken to the theater for cesarean section, we wouldn't want to, risk the woman to go through aspiration or any other thing. And so we encourage light, diet as well as clear fluids. Then we also need to encourage the woman and advise the woman to only push when the cervix is fully dilated with contractions. Now, if the woman does not push only with a fully dilated cervix, what happens is that the cervix will become edematous, and this will cause a lot of problems to the woman. Now, the next thing that we need to do as part of our management is that we need to give IV oxytocin immediately the baby is delivered. And we do this because it will help with the expulsion of the placenta. So the oxytocin is going to cause the contractions of the placenta. And as the oxytocin is going to cause contractions of the uterus. And as the uterus contracts, it deprives blood supply to the placenta, which causes ischemia. And so with time, the placenta begins to detach from the uterine wall. And so we need to give this oxytocin immediately after delivery to, facilitate the expulsion of the placenta as well as reduce the risk of uterine atony and bleeding. This is because when the uterus contracts, it contracts on the blood vessels and causes them or it contracts and causes the ligation of the blood vessels to prevent bleeding. Now, the next thing that we need to do is that we need to continue to monitor the woman at least 2 hours postpartum. This is because in the postpartum period, especially between this period, a lot of complications can occur. Some women may even develop, eclampsia, or some women may even develop, any complications, bleeding, or any other thing. And so it is crucial that we monitor these women when they reach this stage of labor. Now, let's quickly go over the stages of labor. As we said, labor is the regular painful uterine contractions which last for 30 to 45 seconds and must occur in every 4 to 5 minutes and must be accompanied by cervical effacement and dilatation. Now we have various stages of labor. The first stage of labor being the dilatation of the cervix up to 10 centimeters. So from 0 to 10 centimeters dilatation of the cervix is the first stage of labor. Now this first stage of labor is divided into two phases. We have the latent phase, which is from 0 to 3 or 4 centimeters dilatation of the cervix. Then we have the active phase, which is from 4 centimeters to full dilatation of the cervix. And this phase of the latent phase is characterized by rapid dilatation of the cervix, and it is followed by the cardinal movement. Now, we also have the second stage of labor, which is typically the expulsion of the fetus. Then we have the third stage of labor, which is the delivery of the placenta. Then the fourth stage of labor is 2 hours postpartum, and it continues up to 6 weeks, which we call the puerperium. So these are the stages of labor. So let's pick the first stage of labor and look at what goes into it. So the first stage of labor begins with regular uterine contractions and ends with complete cervical dilatation at 10 centimeters. Now, as we said, it is divided into two: latent phase and active phase. The latent phase begins with mild, irregular contractions that softens the cervix as well as shortens the cervix. Then we also have the contractions progressively becoming more rhythmic and stronger in the latent phase. Now, in the active phase, it begins at about 4 centimeters of cervical dilatation, and it is accompanied by rapid cervical dilatation and the descent of the presenting part. Now, this being said, how do we manage the first stage of labor? What we have to do is that we have to periodically assess the frequency and strength of uterine contractions, because if the contractions are weak, it may cause delay, labor. And if the contractions are also so strong, it may also cause, other complications. Now, we also have to, monitor the fetal heart rate at every 15 minutes during and immediately after uterine contractions. This is very, very important, as I explained earlier on, because if uterine contractions are causing deceleration of the fetal heart rate, then it means there's a problem that we need to address. Now, this is a graph depicting cervical dilatation in both the latent and active phase in the first stage of labor. Now, we have the cervical dilatation in centimeters and the time in hours. The latent phase lasts for about 7 to 8 hours, and the cervix must dilate for up to about 3 to 4 centimeters. The rest is followed by the active phase, and the active phase has the acceleration phase, the phase of maximum slope, then the deceleration phase. In the active phase, it starts when the cervix is about 4 centimeters dilated. And as you can see, from the 10th hour to the 12th hour, we had a rapid dilatation of the cervix from about the 4 centimeters to about 8 centimeters over here. This is why we call it the phase of maximum slope, followed by the deceleration phase, which also took about 2 hours. And so from the 12th hour to the 14th hour, we saw that the cervix dilated to 10 centimeters, which is the full dilatation of the cervix. This ends the first stage of labor, and it is continued with the second stage of labor, in which the fetus is delivered. Then in about 30 minutes, we have the placenta also being delivered. Now, the first stage of labor progresses differently amongst the primipara as well as the multipara. And so, latent phase may last for about 15 to 20 hours in the primipara and 12 to 14 hours in the multipara. And in the active phase, it may last for about 5 to 6 hours in the primipara and 4 to 5 hours in the multipara. This is partly due to the fact that the multiparous woman has delivered before, has experience, and so it is easy for the cervix to dilate. Now, the rate of cervical dilatation in the active phase of first stage must be calculated. Now, this will help us to determine if the active phase of labor is prolonging. Now, if the woman comes and is 5 centimeters dilated, and in 2 hours you check and the woman is now 6 centimeters dilated, what it means is that cervical dilatation increased for only 1 centimeter, and so we divide it by 2 hours and we are going to get 0.5. What this means is that there is delay in the active phase of the first stage of labor. Now, if the woman comes and you check and the cervix was 6 centimeters dilated, and now after 2 hours you check and it is 9 centimeters dilated. What it means is that we've had 3 centimeters dilatation in 2 hours, and when we divide 3 by 2 we are getting 1.5, which is very good because the rate of cervical dilatation in primipara must last for about 1.1 to 1.2 centimeters per hour and 1.2 to 1.5 centimeters per hour in the multiparas. And so it is good if we have such dilatation. Now, the second stage lasts for less than 2 hours in the primipara and also less than 1 hour in the multipara. Then the third stage of labor must last for 30 minutes for both the primipara and the multipara. Now, the second stage, as we saw, begins with complete cervical dilatation and ends with the delivery of the fetus. In the nullipara, or someone who has never given birth before, the second stage is said to be prolonged after 3 hours, 3 or more hours. That is if the woman was given regional anesthesia, or 2 hours if there is no regional anesthesia. And in the multiparous woman, the second stage is said to prolong if the second stage lasts more than 2 hours with regional anesthesia, or 1 hour without regional anesthesia. So how do we manage the second stage of labor? Ideally, we need to help the woman assume a comfortable position. Amongst them, we may have the supine position, where we have the woman lying at her back and assuming the lithotomy position, which is usually, the position of choice. But we may also have what we call the Sims position, then, partial sitting or squatting position, in which the woman, it's on her hands as well as on her knees. So these are various positions that we can, assist the woman, to assume. Anyone which is comfortable for the woman is okay. Then we follow the cardinal movement to deliver the baby. So what is cardinal movement? This is also known as the mechanism of labor, and it is the ability of the fetus to maneuver the pelvis during labor by making changes in the position of its head as it passes through the birth canal. There are 7 sequential processes of the cardinal movement which we must know. But before that, it is important to note that when labor starts, the fetus is usually in the occipitotransverse position. Now, the first step in the cardinal movement is the engagement, and this is when the fetal presenting part enters the pelvis, still in the occipitotransverse position. The second step is the descent, which is further downward movement of the baby in the pelvis, still in the occipitotransverse position. Now, during flexion, the fetal head flexes to allow the smallest diameter of the head to present. It is still in the occipitotransverse position, but something happens over here. We see that right after flexion, there is internal rotation of the fetal head, which allows the fetal head to rotate from the occipitotransverse position into the occipito-anterior. Now, the next step is the extension of the fetal head. So the fetal head extends to facilitate the delivery of the head. Then it is followed by restitution and rotation, that's external rotation. Then furthermore, we have the expulsion of the fetus. This is when the fetal body rotates such that the head is in the transverse position. The shoulder or the shoulders are in line with the maternal anteroposterior axis, which facilitates delivery of the shoulders. What do I mean by all these? Let's look at this diagram. This is the beginning, and so over here we see that the head is floating before engagement, as we can find over here. Now, during engagement, flexion and descent, what happens is that the widest diameter of the presenting part, which is the biparietal diameter, enters the maternal pelvis to a level below the plane of the pelvic inlet. And on pelvic examination, the presenting part is usually felt at the level of the maternal ischial spine, and so we say it is zero station, as we find over here. Now, there is further descent and rotation. So the descent is the downward passage of the presenting part through the pelvis, and this is facilitated with, the maternal uterine contractions. Now, during flexion, what happens is that as the fetal head, descends, it encounters the resistance from the bony pelvis as well as the soft tissue of the pelvic floor, and this results in a passive flexion of the fetal, head. And so the chin of the fetus is usually brought in contact with the chest, or the fetal thorax, and this presenting diameter changes from the occipitofrontal, which is 11 centimeters, to suboccipitobregmatic, which is 9.5 centimeters, and this allows for optimal passage through the pelvis. Now, something interesting happens, as I said over here. So during the rotation, or during internal rotation, as the head further descends, the presenting part usually is in a transverse position, and so it is rotated for about 45 degrees anteroposterior. So as you can see, it started from this diagram. It started rotating, gradually moving towards the symphysis pubis. And so over here, when rotation is completed, and during the beginning of flexion, you see that the occiput of the fetus is right under the symphysis pubis. And when this happens, rotation is complete. Now, extension begins. Then, during extension, there is further descent, and the full flexion of the head also takes place. Now, we find that the base of the fetal occiput comes in contact with the inferior margins of the symphysis pubis, as you can find, or as you can see over here. Now, the upward resistance from the pelvic floor and the downward force from the uterine contractions causes the occiput to extend and rotate around the symphysis. And so this is usually followed by the delivery of the fetal head, as you can find over here. So as you can see, the fetal head has rotated again over here. It is followed by restitution. And by restitution, we mean when the fetus head is free of resistance, it untwists itself about 45 degrees left or right. Then it returns to its original anatomic position in relation to its body, as you can find over here. And this is followed by the this is followed by the delivery of the anterior shoulder. Then next, it's followed by the delivery of the posterior shoulder. Then we deliver the baby onto the mother's, abdomen or chest. So this is basically the cardinal movement. The last stage of labor is the third stage of labor, and this is the period between the delivery of the fetus and the delivery of the placenta, as well as the fetal membranes. Now, the delivery of the placenta takes less than 10 minutes. However, the third stage may last as long as 30 minutes. And so any third stage, which is prolonged after 30 minutes, requires an intervention. And so when the woman delivers and you wait after 30 minutes and the placenta has not separated or has not been delivered, then it means there is a problem which needs to be solved. So usually you have to, resort to manual removal of the placenta. Then, as part of the management of the third stage, we have to, give prophylactic administration of oxytocin and some other uterotonics. Then afterwards, we do the cord clamping and cutting. Then we do what we call controlled traction of the umbilical cord to help in the delivery of the placenta. Now, the next thing we must know is, how do we even identify that the placenta has separated? We have three classical signs for the separation of the placenta. The first one being that the uterus contracts and rises into the abdomen. Then we find the umbilical cord suddenly lengthens. Then the final thing that we can also see is the gushing of blood into the vagina. And this gushing of blood is the blood which collected behind the placenta. And so as you try to pull the umbilical towards you, the blood, forcefully comes out into the placenta. And these are the indications that the placenta has been separated. So this is all that I have for you. Thanks for your attention. Bye bye.